Good afternoon, everyone, and thank you for tuning in. It is 2:01 on my clock, so in order to honor your time, I wanted to go ahead and get started. My name is Andrea Watkins, and I am the program supervisor for the Women's Fund, and I am thrilled that you are here because we have some exciting guests today that are going to talk about something that's very important. So I'm going to go ahead and share my screen so I can just kind of get us started. And forgive me if I look over here just because my screen is over here. I know that I was talking about that with Dr. O'Shea. So if you see us turn away, we're still here. We're just wanting to make sure that we get the content correct. And so can everyone see my screen? The
Yes.
Colorful little pictures, perfect. All right, so I'm gonna start off by just introducing the Women's Fund for a couple of minutes. So the Women's Fund, we have been around for over 40 years, and our mission is to provide women and girls with the tools they need to be advocates for their health. And so we do this by hosting lectures like this. We also do it by going into organizations like schools or churches, any other community partner, and we give out health information like talking like a lecture, or if they need publications, which we also give out that are free of charge. We want to make sure that we do what's best for our community in getting the best health information for themselves. If you have your camera and you want to wave it over the QR code that's on your screen, that's going to take you directly to our website where you can download those publications to your desktop free of charge. Any of the services that we do are free of charge thanks to our gracious donors. So if you want to get a group of women together, maybe through your church, and have us come out there and talk to you for about an hour over any topic like stress and coping, we would be happy to do so. And we'll give you more information at the end. But I don't want to take the spotlight too much from our wonderful speakers. We have with us Dr. Michelle O'Shea and Tiffany Carter. We are so happy to have them, and we're just so appreciative that they could give us their time today. So I'm going to give you a quick little bio on them, and then I'm going to turn it over so you can really just get into the meat of it. Let me open. So I'm going to start off with Dr. O'Shea's bio, and then I'll switch it over to Tiffany. So born and raised in New Jersey, Dr. O'Shea received her medical degree from the University of Medicine and Dentistry. Now, is it Rutgers University? Yes,
Rutgers.
Awesome. In 1996, she completed her general surgery residency in New Jersey at St. Barnabas Medical Center.
Barnabas?
Barnabas, thank you.
That's okay, sorry.
I'm not gonna get it in 2001. She joined the Summit Breast Surgical Practice under its founding surgeon, Dr. Jan Huston, and became president of the practice in 2009. In her 20-year breast practice in New Jersey, she provided breast surgery to women in 5 counties in northern New Jersey, 3 counties in Pennsylvania, and 2 counties in New York State. She was the chief of surgery at Newton Medical Center in 2014 through 2015, as well as the chair of its cancers committee in 2013 through 2015. She became the director of breast services at Hackensack, I'm sure I said that wrong, University Medical Centers, yay, Mountainside Hospital in Montclair, New Jersey in 2017. She is a member of the American College of Surgeons and American Society of Breast Surgeons. Dr. O'Shea has been named a New Jersey top doctor since 2012 and a Texas top doctor in 2021. Wow, congratulations.
Thank you.
She has received the Emerging Physician Leader Award from Newton Medical Center, a Distinguished Alumna Award from her alma mater, the College of St. Elizabeth, and the Patient's Choice Compassionate Doctor Award. She joined her colleague from residency, Dr. Sandra Templeton at Houston Methodist Breast Surgery Partners at Sugar Land in 2020, and is excited to be treating women at the Houston Methodist Sugar Land. Wow, that is an impressive bio.
Thank you.
All right.
I should have made it a lot shorter, so thank you.
No, I love it because it's good to be recognized. And then now moving to Tiffany Carter's bio. So for more than 12 years, Tiffany Carter has worked as a board certified genetic counselor. She has an affinity for cancer genetics, focusing on its hereditary, I can't speak today, my apologies, aspects.
Doing
She
great.
counsels patients and their families who may be at a higher risk of developing cancer. Tiffany says she is grateful to share her knowledge of genetics to empower patients to make informed decisions related to their health and the care of their loved ones. She serves patients at Houston Methodist Sugar Land and at Houston Methodist West. I am so happy to turn over the presentation over to these two experts, and I will stop sharing my screen and hand it over to you guys.
Great. Thank you so much, Andrea. And you know, what a great group your organization is, and we really appreciate the chance to come and speak. And thank you all for your time for being on the Zoom call with us. We really appreciate it. So I don't know about everybody else, but October, can you see my screen okay on my slides?
Can't see your slides yet.
Can't see my slides yet. Okay, hold on. How about now?
Yes.
Okay. Okay, sorry, still getting the hang of this 18 months later, right? Okay, so I don't know about everybody else, but the end of October can be the end of a very stressful month when we're all worried about breast cancer and focusing on it and paranoid about it. So for a very diverse group of women, and more importantly for helping women empower knowledge for themselves and be their own advocate, I thought I'd talk about not only breast cancer, but just how to approach breast in general, because breast exam and breast imaging can be confusing, and maybe answer some myths. And Tiffany will help us jump in and tell us about how family history and genes contribute to breast cancer risk. So I thought I'd talk about breast health and cancer overall to help us take a deep breath and move from October into November after our busy Breast Cancer Awareness Month. Okay, so basically, you know, it always starts with the breast exam. I get many women in the office that say, I don't know what to feel. I don't know how to feel. I get very scared when I feel my breast. So we'll go over that. Also, when people have symptoms in their breast, I get lots of questions about what is this thing I'm feeling? Is it cancer? Which symptoms in the breast can generate a lot of fear. And what is really breast cancer risk, and how do we really find breast cancer and talk about breast cancer screening? So basically, to start with the breast exam, most women are told if you're over 40 and doing your imaging that your breast is lumpy or dense, and most breasts are. So I tell people the way to picture it is the breast is lumpy like a bunch of grapes. So if you picture the grapes in the grocery store and throw a blanket over it, that's your breast. If the breast is heavier or more fatty, it's got a thicker blanket. And if it's thinner or more dense and lumpy and younger, it has a thin sheet over it and not much tissue to cushion those grapes. And then when a woman does her breast exam, the first thing is to just look at your breasts in the mirror. Do they look symmetrical? Is there anything that's been different about the color or something that wasn't there before on your skin? Look at the shape of your nipple. Is it always like it was? Now, everybody has very different variations of how the breasts look, but you just want to make sure it's always looked that way for you. The best way to examine a breast is to feel it lying down or lying flat or with an arm raised in the shower, because that will help flatten out all of the breast tissue and make it easier to feel. Never ever grab your breast with between two fingers or two hands, because it makes everything feel very scary. And comparison from side to side is a good reference, although be warned that breasts don't always match and some areas can be a little mismatched. Everybody panics about an inverted nipple because everybody can Google an inverted nipple. So the nipple on the left technically is an inverted nipple, but it's normal when just the center of it is kind of dented in a little bit, almost like a duck beak. It's actually a normal version of breast tissue. The inverted nipple that makes us suspicious for cancer is like on the picture on the right, where the nipple used to be out and normal and now is kind of stuck in. And that can be a sign that a cancer is growing behind the nipple and pulling on the ligaments and pulling on the nipple itself. So sometimes even if a woman can't feel a lump, just the change in the nipple is enough to tell us that we should be looking for something there. Cancers don't typically present with obvious findings that you can see on exam, but these are certainly examples of what scares women to death. But these are common infections. Mastitis on the left is a breast infection in the tissue. It doesn't accumulate a collection of pus or fluid, but is general cellulitis or tissue infection. That can happen at any age and to anyone. It doesn't necessarily have to be breastfeeding women, and it doesn't necessarily have to have a trigger. This will usually present as an infection, increasing redness, increasing pain, symptoms of infection like fever and fatigue and chills, and is easily treated with antibiotics. If the infection continues and progresses, then we come to the picture on the right, which is what we call an abscess, a collection of pus under the skin in an area of an infection. These look very scary and they're very painful. Again, the woman will have all the symptoms of an infection. Fever, chills, fatigue, increasing breast pain, increasing breast redness. And these are not treated well with antibiotics. They have to be drained, like draining an abscess, or for Dr. Pimple Popper watchers, popping a zit. You have to get the pus out for it to get better. But these are not signs of cancer. Signs of cancer that we sometimes see, but are still not that common, are skin retraction, where on the left, some of the skin actually dimples in, not related to a previous scar or surgery, and that is a new finding. Or something called peau d'orange that looks like the skin of an orange. This is when breast cancer can get into the lymphatic channels, the little channels in the skin, and it gives the skin a very quilted appearance or an orange peel appearance. Most people are Googling these on a daily basis if they find a problem with the breast, but these are only how 1% of cancers present, so you're not going to see them that commonly. If the skin change alone or how a lumpy breast feels on exam isn't enough to scare you to death, if the woman feels a lump, good luck if she doesn't pass out and hit the floor just from fear. But lump does not always mean a bad thing. It just means something that's changed that we need to figure out. So you can't always feel a lump, see a lump, but sometimes you can. The only way to know what a lump is to do imaging, and usually we'll mammogram a breast lump, but especially if a woman's under 30, ultrasound is the way to go. And we always use ultrasound with a mammogram if a woman's over 40. And most of these lumps tend to be simple cysts, which are not cancer and don't increase your risk for cancer. That's the top picture that you can see on the screen. Sometimes it's a little solid lump called a fibroadenoma. These do not increase risk for cancer, but they are lumps that we can feel. And sometimes it's a cancer that we're seeing and finding that we need to find. So if a woman actually feels a lump or her doctor feels one, imaging is really what's going to help us decide what it is. You can't know without seeing an image of it. And then symptoms. Breast pain is very common thing that frightens women into thinking they have breast cancer, but breast pain is actually rarely a symptom of breast cancer. Breast cancers usually tend to show as painless lumps. If a woman has breast pain that is in one or both breasts, that comes and goes and is random, it's not the same spot all the time, every time, and there's no lump associated with it, the good news is that that is normal breast pain. And there's a lot of normal breast pain that we don't talk about. The two most common causes are hormone changes up and down, sometimes with our period, sometimes when young girls are first getting their period, or when women are going through menopause. And stress is the #2 cause of breast pain. So certainly we probably should all have breast pain for the last 2 years that we've had. We work up breast pain when it tends to be in one breast that's not going away, that it can be localized or identified in one single spot that's getting worse. And then the things we tend to look for are more commonly infections and cysts, but sometimes cancer. So those are some of the ways where we cannot be so anxious about our breast symptoms. Again, breast pain, it's a common conversation. I have it multiple times a day with patients. If it comes and goes, it's typically normal breast pain. If it's in both breasts, the first question I ask is, are you pregnant? Because some women, the first sign of pregnancy is breast pain. Or you can even just look and say, am I about to get my period? Am I going through a hormone cycle? The best treatment for breast pain is reassurance that it's not breast cancer and a sport bra for support. It is not affected by caffeine and chocolate. That is a myth. And vitamin E does not make it better. That is also a myth. I think I went through that. And so those are some basic, simple problem solving that we can do with the breast, but always talk to your provider if there's a concern. And so who is at risk for breast cancer? The biggest risks for breast cancer are being a woman and getting older. And so I probably have a varied group on the Zoom call. If you look at a 30-year-old woman, her 10-year risk of getting breast cancer is only about 1 in 225. But a woman who's 70 has a breast cancer risk in the next 10 years of 1 in 25. So your risk increases for every decade, similar to how the risk increases for men with prostate cancer. 85% of women with breast cancer do not have a family history for breast cancer. So while it's very important that we have Tiffany here to talk about when our family history impacts our breast cancer risk, most women with breast cancer do not have a family history. And so I'm going to turn it over to Tiffany to talk about how family history is an important part of breast cancer risk. Sorry, Tiffany. I'm going to see if I can stop sharing my screen.
Thank you, Dr. O'Shea.
Or if you, let me see, can you take over your screen?
I think so.
Sorry about this. There we go.
Perfect. Thank you so much. Let me just put it into presentation mode. So I just want to go over a few things. Dr. O'Shea has covered a lot of it. But the biggest breast cancer risk, as she mentioned, are advancing age, being a woman, reproductive history, which we'll talk about a little bit later, and I'm sure she'll touch on as well. Breast density, lifestyle factors, and then of course, family history and whether there's a genetic cause for the increased risk in the family. And so we know, as Dr. O'Shea mentioned, that the majority of breast cancer occurs just by chance or sporadically. Again, advancing age is one of those risk factors. So as a woman ages, we know that the risk often increases. And then about 15 to 20% of the time, we can see that there are familial factors. So those are factors such as we see individuals with multiple individuals in the family who've been diagnosed with breast cancer, but we do genetic testing and we cannot identify a mutation that's increasing the risk or a change in the gene that's causing that increased risk. So we know that families share, their environment. They grow up typically in similar places, have similar lifestyles, have similar habits. And so sometimes those things can influence risk as well. And sometimes we can do genetic testing, and because we don't yet know all the factors, genetic factors that influence breast cancer risk or cancer risk in general, then perhaps we're missing something. Perhaps it's something there we can't pick up on the analysis that we do yet. Or maybe we haven't discovered the gene for that family yet. And then about 5 to 10% of the time, there is a change in a gene or a mutation that we can identify that's increasing the risk for breast cancer. And we know that about 1 in 8 women will get breast cancer in their lifetime. And this is outside of any family history. So that does not include family history. So as Dr. O'Shea mentioned, every woman has a risk for breast cancer. And so I want to talk a little bit about the social determinants of health, because we know that that also influences whether individuals get breast cancer or other types of cancers or not. So the conditions where individuals are born, live, work, play, worship, age, and all affect their health and risk of outcomes. And so all of these factors can also contribute to whether individuals are exposed or have some risk factors for health disparities. And so there's a current campaign called healthypeople.gov to identify some of these health disparities in our communities and to lessen them, hopefully eliminate them over time. And also the Centers for Disease Control is also doing some research on this currently. So we know that just like there are health disparities in other aspects of healthcare, genetics is not immune to it. There was a study done by Chapman and Davis in 2020, last year, that showed that individuals who have lower incomes and are of color, patients of color, are less likely to receive a diagnosis, less likely to be offered genetic testing or receive a genetic counseling referral, and less likely to have their family history collected at their appointments. So it's important that if you do know that there's a family history of breast cancer, that you let your providers, let your doctors know that that is the case, so that they can make sure that you're referred to breast surgery, to genetic counseling, to look at those risk factors to determine your personalized risk. And if you qualify for genetic testing. And there are ways that we can also mitigate some of those costs as well. In some cases, genetic testing is much more affordable than it used to be back in the day. So certainly there are things we can do to help with that. So if you're requesting and preparing for a genetic counseling visit, again, you want to talk to your doctor about your family history of cancer. You can request a referral with us through I see patients at Houston Methodist Sugar Land and Houston Methodist West, and you can contact medical oncology or breast surgery at those locations. When you come to the visit, you want to bring your family health history, and we want to make sure that you get information from both your mother and father sides of the family. Both sides are important when we're looking at cancer risk. Sometimes patients don't realize that their father's side of the family is important, but it certainly is, and it does count. So we like to know that information as well. If you've been diagnosed or you have a close relative that you can access pathology reports from them or treatment plans or a chart note from their surgery, then that's helpful as well. Any genetic testing results that you've already had done or your family member has had done, we like to have those as well. Those are extremely helpful when we're trying to determine if you need to have genetic testing, if we can look at the mutation or the change in the gene that's been identified in the family. The lab often asks for that as well. So we like to have that information as well. And you may need update testing. Maybe you were tested 10 years ago or even 5 years ago. It would be, it may be helpful for us to look at that and see what you've been tested for. Or maybe you only got tested for BRCA1 and 2, which we're going to talk about in just a second. So expanding that panel can be helpful as well. Bring your questions and your concerns so that we can address those and put any anxieties or any concerns that you have, calm those hopefully. And then we like to know the cancers in the family, the types of cancers, age of diagnosis, ages of death, and those kinds of things are very helpful. Also, the degree of relationship to you. So if they're close relatives like mother or father, brother or sister, those are first degree relatives. Aunts, uncles, even great uncles, grandparents, all of those are great uncles and aunts and grandparents and first cousins are also important. And so when you come in for your appointment, we draw it out as a pedigree. And so this allows us to see patterns in the family so that we can get a better idea of whether there are cancers running in the family or not, and from which side those are coming from and how closely those individuals are related to you. It's important to get updated information. So if you can, please bring the most updated information with you. Also, if you want to track your own family history, you can do that. There is a website called My Family Health Portrait that the Surgeon General has created, and you can go online and create your own pedigree, or you can create, which pedigree looks like this that you can create, or you can create a spreadsheet, whichever way is most helpful for you to follow that family history and update it as often as you need to. And it's just for you, it's not stored on the website. And so it's so important to know your family history, share any breast cancer diagnoses in the family or cancers diagnoses in the family. Make sure that you're collecting that information, documenting it, and then making sure that you're educating yourself and supporting your family members, making sure that they're aware of that information as well so that they can let their doctors know about it. And so genes are important because they're in all the cells of our body. They're the instructions that tell us what our hair color, eye color, skin color will be, where our organs are placed in the body, how they function, how we think, act, feel, and learn. And they play a significant role in whether individuals get cancer or not. And so we get half of our genes from mom and half from dad. And that's why both sides of the family history is important. Our genes come in pairs, and if we do find a gene change in the family, then it's a 50% chance to pass it down. And so the two most common genes that we think about, because they carry the highest increased risk for breast cancer that we're currently aware of, are BRCA1 and 2, but they're not the only genes that we look for when we do genetic testing. And so it's important to get an expanded panel. And this is just giving you an idea of what the breast cancer risk might increase to if there is a BRCA change in the family. And so it's a 50% chance to pass it down because our genes come in pairs. So either you pass down the gene that does not have the mutation or change in the gene, or you pass down the gene that does. We know that some of these genes are related to the different types of breast cancers that we see arising in the clinic. And so this is why we want to expand that panel a little bit. And also there's been some recent research that came out earlier this year that showed that individuals who are of Black or African American descent may have an increased risk for genes like BARD1, RAD51C, and RAD51D that can increase their breast cancer risk. And these genes also increase risk for other types of cancers like ovarian cancer. And so you can ask for testing at your PCP, your breast surgeon, oncologist, or you can do direct to consumer testing. It's not recommended, but you can go online at certain companies and order this testing. If you do that, make sure that you share those results with your doctor so that they can go over them with you. Make sure you've been tested for through the appropriate company that's going to do the right analysis, and also an analysis that we trust, and also that you've covered the genes that you need to cover based on your family history. So I'm going to turn it back over to you, Dr. O'Shea.
Great, thank you.
And I think, can I stop sharing? Maybe you should take it back.
Let me see if I can. All right, that's good. Can everybody see my screen now?
Not yet.
Not yet. Okay, hold on. We're getting there. How about now?
Yeah.
Okay, good. So wow, that's fantastic. I learned a lot in that. Thank you, Tiffany. I really appreciate it. And so how do you sum up everything that Tiffany said? And a common question that Tiffany and I often get is, well, should everyone just be randomly tested for breast cancer genes? And family history is important. And we're talking more than just the BRCA1 and BRCA2, but we get the most questions about BRCA1 and BRCA2. And so really the basic guidelines that we tell our patients is that if a family has more than one family member with breast or ovarian cancer by age 50 or sometimes 60, then we want to consider getting to a genetic counselor or talking to our doctors about genetic testing. Certainly, if there's a pattern of multiple family members with multiple cancers, that's the role for the Tiffanys of the world that help us figure it out. The current gene panel that we run in our office can be as high as 84 different genes that we're looking for mutations. And so that's very important information. But just randomly, everyone off the street doesn't really benefit from genetic testing. So we want to look for those patterns. We test all women diagnosed with breast cancer in our office pretty much before age 60. And then after 60, we really look at family history as well. So that's so helpful. Thank you very much. When we talk about, let me get back to my screen. Okay, so what did we say? The biggest risk of breast cancer are being a woman and getting older, and family history does play a role in up to 25% of cancers. So how do we fight that risk? We can't control any of that. So what are the risk factors that we can control, and how can we help reduce our risk? So there are 5 things that we can do to be proactive in our fight against breast cancer. Number 1, maintaining a healthy weight. Why? Because, unfortunately, as women go through menopause, weight gain is common from the change in hormone status and metabolism. And when you go through menopause and your ovaries are not making estrogen, you're not getting your periods, the fat cells in our bodies take over. And so when we go through menopause, we don't become men. We still have estrogen on board. It's made in our fat cells. So having extra weight on board will mean having extra estrogen on board. And it is our estrogen exposure over our lifetime that does contribute to our risk for breast cancer. Be active. So believe it or not, even as little as walking 2.5 to 5 hours a week can help reduce our risk for breast cancer. So staying active helps us keep a good body weight, helps us keep our metabolism higher. And 300 minutes per week has been shown in breast cancer survivors to help reduce the risk of breast cancer coming back. So everybody get moving. And after sitting around the house for 18 months, probably all want to do that anyway. Eat healthy. Everyone always asks my breast cancer patients, did my diet cause this? Is there something that I'm doing wrong? And we don't really know the true cause of breast cancer, the exact damage that occurs to create the cancer. If it was just a food issue, probably we would all have breast cancer. And actually, our breast cancer rates in the United States are decreasing slightly. So it's not just about food, but if you want to talk about the best food, you hear all kinds of recommendations and websites and Facebook groups, but whole foods over processed foods and sugars are definitely a pretty solid recommendation in terms of changing diet. Limiting alcohol, and this can be a little bit rough, but studies do show that drinking less than 1 drink a day can help reduce your risk for breast cancer. And help breast cancer survivors reduce the risk of it coming back. So don't mean that you have to abstain completely, but glass of wine every day with dinner is probably too much wine. And you have to look at the perspective. Glass of wine that counts is a 6-ounce pour. Many of us might be guilty of a little bit more than that. And so I tell my patients, even my breast cancer patients and survivors, if you're going on a cruise, enjoy the open bar. But when you get home, you need to have a little bit of a dry spell. So an average of less than 1 drink a day are the current guidelines to help reduce breast cancer risk. And limiting hormone use. Now, not all hormones are dangerous for breast cancer. That's a myth. But combined estrogen and progesterone together, the common hormone replacement that women were getting in the 50s through the 80s, does increase your risk for breast cancer. And so if women don't need that hormone replacement because of severe symptoms that are affecting their lifestyle, then it's not recommended. Even our breast cancer survivors can do vaginal estrogen cream, and that does not increase risk, and it helps with symptoms. For women that are having very severe symptoms of menopause and need some hormone replacement, it can be done. It should be supervised by a physician, and things like family history play an important part. But the biggest thing is to know your risk if you're going on the world of hormone replacement, and what hormone replacement would least reduce your risk for breast cancer. And those are important things to know and to consider. Some myths that we always get asked whenever we do our talks, so I thought I'd just jump in them so you don't have to type them in the chat. Breast cancer risk is not increased by soy in our diet, and that's pretty common as people are going to plant-based diets. Soy is a plant-based isoflavone, which is an estrogen imposter. It looks like estrogen in our bodies, but doesn't necessarily act the same as estrogen in our bodies. In the human studies on soy, there is no risk or maybe even there could be a decreased risk for breast cancer because it looks like estrogen but doesn't act like estrogen. So it's an imposter, but it doesn't do anything bad for us. And so it could fill all of those parking spaces with inactive molecules. But soy in our diet does not increase our risk for breast cancer. Deodorant in our diet does not increase our risk for breast cancer. I know there's a movement to go to less processed everything, and that's good for us and good for our environment. But deodorant has not been linked to increased risk for breast cancer. And underwire bras do not increase risk for breast cancer. And so there's no evidence behind those myths. So feel free to enjoy what you use in life. How do we find breast cancer? So those are some ways we can reduce our risk. The most important thing is we can't always prevent ourselves from getting breast cancer. We have to find it when it happens. The best way to find breast cancer is to screen for breast cancer. All of our studies show us that screening mammograms saves lives from breast cancer by helping us find it as soon as possible. When countries developed a screening mammogram program, each country saw 15 to 25% reduction in death from breast cancer. So mammograms do save lives. Now we have even higher tech mammograms. So it used to be just an X-ray, like you're looking at a bone fracture, but now we have very high resolution X-rays. These are called 3D or tomosynthesis. These help us with the dense breasts that we're on a mammogram. I'll go to my next picture. On a mammogram in a dense breast, this picture is of a pretty classic digital picture, not even the film picture. But in a digital mammogram, the hormonal breast tissue or the dense lumpy breast tissue comes out white, and a cancer will be a white lump or white calcifications in that tissue. So the more white the background is on the mammogram, the harder it is to find a smaller cancer. And so one thing that's been developed to help kind of see through all the denseness is a 3D picture. And this isn't a flat picture of your breast. It takes a picture of your breast in an arc and then builds the images together so that you can see when a cancer is in the breast more clearly. And many women, especially between the ages of 40 and 50, get a lot of callbacks for their mammograms for areas that need to be smoothed out because they're a little bit too white or a little bit too patchy. And these 3D mammograms help improve that. And so here at Methodist in Sugar Land, all of our imaging is now 3D or tomosynthesis, which actually gives us a much better picture and increases the effectiveness of a mammogram. If anything is found on a mammogram, then we typically will then go to ultrasound. And then sometimes women, we don't see a finding that's suspicious and we say, come back in a year or come back in 6 months. And sometimes we do see something that needs a biopsy, and often your doctor will send you to a surgeon like me or to a breast center first for a biopsy. And then we go from there. And so we recommend screening mammogram for women yearly, starting at age 40. The studies show us that the women who are screened between the ages of 40 and 50 represent the most years of life saved by screening mammogram. So the government recommended in 2007, I believe, that only women over 50 have mammograms, but the American Society of Breast Surgeons and the national guidelines and the American College of Obstetrics and the American College of Surgeons recommend screening at 40, because between 40 and 50, that is when the mammogram is most effective at saving lives. If a woman has a 10-year life expectancy, we still do screening mammograms. So we always get the question of how old is too old? And the answer is there is no upper limit. If a woman can walk into my office and walk up to the mammogram machine, she's healthy enough to be screened for a cancer. If a woman has to be wheeled up to the mammogram machine or explained what it is every 5 minutes, we probably don't need a screening mammogram. And so once we get older, it really depends on the health of the individual person as to whether a screening mammogram is appropriate. That's a lot of information in a short period of time on a Zoom phone call, but our goal is to just give people some basic information. We're certainly happy to answer any questions at any time. I know the center will have our slides available if anybody wants them. But that's it. I just wanted to keep it short and sweet. Does anybody have any questions? And once again, we thank the Women's Fund. What a great group and a great organization that needs everybody's support.
Thank you so much, Dr. O'Shea. Tiffany, you want to add something?
I just wanted to say thank you all as well. It's been such a great opportunity to talk with the Women's Fund, and we look forward to doing it again sometime.
Absolutely.
So much. No, really, thank you for your time. I know that you have very busy schedules, so you taking time out of your day. We are so appreciative for it. So this time, oh, I'm so sorry, my dog is barking. Sorry, he saw a squirrel and he's probably still gonna bark. But I want to open up the floor to any questions. If anyone has any, you can put it in the chat, you can unmute yourself, whatever it is that you would like. We'll answer a couple of questions for a few minutes.
Hope they didn't bore everybody.
No, I found it fascinating. Is it okay if I ask a question just to maybe kick things off?
Yes, absolutely.
So I know that, all of this information, we're armed with it and we're like, okay, yes. But then the moment that you do feel a lump, or the moment that you do, like, your doctor tells you something, there must be like such an emotional toll that happens to us. Do you know, like, what is a good recommendation? Like, after we did the doctor's visit or after we felt a lump, what can we do for like emotional support with this kind of stuff?
That's a great question. And, I always tell my patients, many people, not even having cancer, just having to come to our office for a problem in their breast, you have to peel them off the ceiling first, because especially if you Google anything, right away you come to our most aggressive forms of cancer, which are actually pretty rare. So before people jump on Google and Google MD and Facebook, I think it's important to start with the primary doctor that's addressing the issue, a GYN or a primary care or a breast surgeon. See what they have to say first. But even breast cancer is not necessarily an emergency. We don't have to drop everything and run and take off both breasts. We have time to build the information that we need to make an appropriate plan. So even a breast cancer is not an immediate threat to a survival, although stress-wise it can be. And so there are, the American Cancer Society has a great initial support groups, and there's lots of community groups. I think the biggest thing, first of all, is ask the doctor that you know and respect for a recommendation for a local support group if that's needed. And most importantly, just stay off the internet until you have some basic information, because it's hard. It's very easy to get caught up in other people's results, but you don't know what yours are and what it means for you. So I would have a solid information on my problem before you start going to a support group, because you might get misdirected and then have even more anxiety.
Dr. O'Shea, this is Yolanda, if I can just chime in. So we
Sure.
here at Houston Methodist also have a plethora of different support survivorship programs that we offer, and they're all free to the community. So around that, not only do we have support groups for breast cancer patients and survivors and caregivers, but we also have general cancer support. We also provide psychosocial programs that include yoga and art and massage and music. And right now we're all meeting virtually, but definitely they do provide some fellowship and some camaraderie, and certainly hope and encouragement by the conversations that take place amongst those that participate. So I'll be happy to share our flyers with you. And you can pass it along to your constituents.
Yeah, and they're really wonderful programs. And even patients that we see in the office, either in the breast center or in the surgeon's office here at Methodist, they meet with someone called a nurse navigator that also helps connect to our community programs, our other doctors' offices, answering simple questions. They really can literally steer the ship for the patient if the patient doesn't know what to do. So our navigators are also great resources to have.
Thank you. That's a really good metaphor. You don't know where to take your ship, but you've got navigators there to help you.
Exactly.
Because I can only imagine what it's like. So thank you for sharing that, Yolanda. That's really great information. And if you want to pass that on to me, or the slide that I'm about to put out, I can give that flyer or more information to anyone who would like to know. So I'm going to go ahead and share my screen just for last minute content. Let's see. Can you see my screen? I think you can.
Not yet. Now again.
Okay, awesome. So if you're anything like me and you're thinking you're driving home or you're just pondering on something and you have a question that pops up, please feel free to email us at healtheducator@thewomensfund.org. With that being said, we will send you any information that we get that we can pass on to you for you to have more resources in your toolbox. And if you do have a quick minute or two to take to wave your phone over that QR code, that is the link that will take you to our survey. We are always looking for feedback to make these presentations better for you. And we want to make sure that we give you maybe change it time-wise, or maybe you want to hear more on a certain subject. We are open to feedback. And of course, the last slide, if you want to follow us on any of our socials, there we post the most up-to-date information, like when the next awareness series is and what the topic is. So again, I want to really thank you for your time. Thank you again, Dr. O'Shea and Ms. Carter. We are so happy that we can have people like you in our community to help us and educate us on things that are so important.
And really, thanks for the opportunity. The Women's Fund is doing great things for our community. We appreciate it.
Yes,
So
thank
with that, I'll conclude the meeting. And again, thank you so much, everybody.
Thank you. Have a good day.
Thank you. Bye-bye.